Okay, hello everybody. This is Terry with the Premom team, and we have three expert panelists with us today for our Premom panel on PCOS. This is a very important topic, and I know you're excited to see this. So we're going to jump in and get started. We had a lot of great questions from you. We're going to mostly just be covering those questions as much as we can. If we have some follow-up questions related to those, though, please feel free to ask those in the Q&A section, and we'll check those out at the end if we have some time. So today we have with us Nurse Linda.
Good morning.
She's a registered nurse. And we have Brianna Kane.
Hi.
Also a registered nurse. And Dr. Haebe.
Hi, good morning. Happy Friday.
A naturopathic doctor. And let's get started with what PCOS is. We're going to start with Nurse Linda. Can you tell us about how PCOS is diagnosed, what lab tests might be run? Go ahead and jump in.
Sure, the boring part. Okay, let's do that. So PCOS, Polycystic Ovarian Syndrome, is usually diagnosed a couple of different ways. One can be without any intervention at all. You're going to look at symptoms such as anovulation. I don't ovulate. I don't have periods. That's like the most obvious one. There can be issues with putting on weight easy. There can be excess hair growth on the body in places there's not supposed to be excess hair growth, acne, that kind of thing. So those are things that somebody could just think about at home and think about if that might apply to them. Diagnosing it with a physician is usually a twofold kind of thing. One is going to be an ultrasound. An ultrasound, a vaginal ultrasound especially, is going to take a look at the ovaries. And when you have PCOS, your ovaries look a certain way. Sometimes they refer to it as a pearl necklace, simply because you grow what I call a bunch of baby follicles that never really go anywhere. And so your ovaries look chock full of these little white bumps, follicles that aren't doing anything. So it looks like a polycystic ovary. Lots of cysts, follicles, same thing. Follicles have eggs in them. So they refer to it as pearl necklace. Also lab tests. There are certain lab tests looking at your FSH and LH. There's usually a reversed ratio. Generally, your follicle stimulating hormone is a little bit higher than your luteinizing hormone. But when you have PCOS, you tend to see a flip there, and the luteinizing hormone tends to be a little bit higher than the follicle stimulating hormone. Those labs are generally done about day 2 or 3 of your period. Otherwise, there are other hormones to look at, such as testosterone, androstenedione, DHEAS. These are just hormones, again, that normally when you don't have PCOS should fall in normal ranges, but it is another way to diagnose it. What's really important to know here is that usually most people don't qualify on all things to be PCOS, maybe just a couple of things. I was diagnosed with PCOS many, many years ago. My doctor literally said, "You are classic PCOS." So I was lucky enough to have literally everything. So it was easy for me to know, but not everybody does have those issues. But that's basically how one would diagnose it.
Do you see there is different types of PCOS? I know sometimes it's related to insulin resistance, but then it's also talked about as other types without insulin resistance.
Right. There is. The most common is the insulin resistant one. And that means it's more of a metabolically based PCOS, meaning it has to do with maybe your food intake or just how your body runs on the inside. It's an issue. It's not just an issue with getting pregnant, but it's going to become a metabolic issue. Again, those of us who are diagnosed with it are more likely to have higher glucose levels because we are insulin resistant. Our body doesn't react to insulin the way it's supposed to. So I tend to have higher sugar levels. And that, of course, can be a problem down the road, metabolically for anybody. But PCOS women if you're in that insulin resistant metabolic group, but not everybody is. Again, those gals like me will tend to fight their weight most of their life, etc. There are other versions that are not metabolically based, like you'll see slimmer girls, sometimes even girls who have regular periods, and they also will fall into some kind of a PCOS diagnosis. It can be inflammatory based, stress, diet certainly plays roles in that. So there are different versions. In the end, when you're trying to get pregnant, it all does boil down to the same thing, and that is getting you to ovulate, regardless of what kind you have.
Can you touch on some of the causes and management? Like someone was asking if it's hereditary and if there's a cure.
Well, okay, that last question is easy. No, there's not a cure. It's a syndrome by definition. So there is no cure. There is no, I won't say there's no fix for it, because there is a fix in some cases, but there's no cure. Is it genetic or hereditary? They think there might be some components of that, but they're not sure. It's not any kind of direct hereditary thing, like, oh, my mom had it, so I'm bound to have it kind of thing. Like I said, I had the classic version. I was textbook, and yet my oldest daughter, who's 32 now, easily got pregnant with 2 children without a problem. She doesn't have it at all. It's funny. It's one of those things that when my daughters got old enough to be having periods, I was so excited when they had regular periods, so they wouldn't have to go through what I went through. But they do think sometimes there might be some kind of a genetic component to it. The causes, I don't think anybody knows exactly what the causes are of it for sure. It's just one of those things right now that we can't put a finger on. There are treatments for it. Certainly diet, weight regulation, that type of thing. I will tell you, again, for me, this is just me as my own little case study. My PCOS was very weight dependent. When I went off the pill, which is how a lot of girls learn they have PCOS, you're on a birth control pill, so of course you have regular periods. The pill causes that, so you think you're normal. Then you go off the pill, like I did when I got married, and then where did the periods go? I don't know. Well, I was maybe secretly PCOS all those years underneath. And so again, the pill kind of fooled me. Now I put on weight really fast, like didn't even eat the kind of foods that should have put on weight, just like didn't make sense. And when my weight would get above 150-ish, this again, just me personally, my periods would stop. If I got below 150, they would slowly come back. And when I had periods, and I've got 3 children, remember I'm classic PCO, and I've got 3 children that I conceived naturally. It was because my weight was always down below 150 and I was having periods. Because when you're PCOS, there's nothing wrong with your eggs. There's nothing wrong with your uterus. It's a matter of trying to get those hormones all to cycle right so that we can get you to ovulate so you can get pregnant. Now, I did do IVFs, and those are always a nightmare when you're PCOS, and they didn't work many, many years ago, over 20 years ago. Over 25 years ago, goodness. So again, for me, I could regulate the PCOS better by eating a better diet, low carb, Mediterranean type of thing. That's what they recommend and suggest, and it worked for me.
Great. That's great. We had some questions about weight in particular, so thank you for touching on that too. You mentioned earlier some symptoms of PCOS. You talked about the classic PCOS. Is it possible to know that you have PCOS without a doctor confirming it?
Well, again, it was easy for somebody like me. Again, I put on weight. I know when I put on weight from eating. We all do. This was not that. This was like stupid, crazy, fast putting on of weight that I did not deserve. And again, and I had hair I think it was actually my tummy when the doc saw me, and he looked at his nurse and went, yeah, she's classic PCOS. So again, I could have a full beard. I have to get waxing. So I had hair growing in all kind of places that shouldn't. So that was there, not ovulating, weight gain. So just by looking things up, I didn't need to go to a doctor. I knew I had PCOS. And then when I went, it was confirmed. So yeah, unlike, well, gosh, there are symptoms to endometriosis, but maybe like pelvic inflammatory disease. Somebody might not know they have that. So you have to go to a doctor to get diagnosed. Or men have low sperm counts. They might not know that. They have to go to a doctor to get diagnosed. PCOS, often you can tap into that you have it by your symptoms.
That something's going on. Okay. And then we had a question
Right.
about how is it diagnosed when you only meet one criteria? I think it's the endocrinologist was talking about it being related to being overweight. I guess there's just some confusion about whether they really have it or not. I'm not sure I fully answered that question.
Right. Well, I mean, in the end, like I said, I mean, imagine there are, I don't know, 15 different diagnostic tools, including what you see, and feel, along with labs and ultrasound. So there's a lot of things that can help diagnose it. Again, I probably had 15 out of 15 were flagged, but maybe somebody only has 5 out of 15. So you don't necessarily have all the symptoms. Again, in the end, PCOS is an issue if you're trying to get pregnant, and PCOS is an issue if you've got the metabolic version, where you have to start paying attention to other parts of your health to make sure things don't go wrong. That has nothing to do with you getting pregnant.
Okay, let me just peek at the Q&A really fast. Okay, it looks like it's an LH strip question, so we'll save that for the end. Okay, thank you, Nurse Linda. Let's switch over to Brianna Kane for some questions.
Sure.
Brianna, what is the chance of conceiving with PCOS, and what are your thoughts on how to naturally conceive with PCOS?
So PCOS actually in related to conceiving with PCOS, over the life of a female, whether they're PCOS or non-PCOS, you basically have the same chance of pregnancy as someone who doesn't have PCOS. Like Linda was saying, Nurse Linda was saying, she has classic PCOS, had all the symptoms, but she was able to have 3 children, while dealing with PCOS. So it does depend on your age, how often you ovulate. So if you don't have periods and you're not ovulating, then obviously your chance of pregnancy is going to be really low. But on average, just with being able to kind of help with these symptoms and help you regulate ovulating, you have a really good chance of pregnancy. And like I said, there's not really a huge difference, statistically speaking, between people being able to get pregnant with PCOS and without PCOS. It's very similar. As far as being able to naturally help with conceiving, she talked about the different types of PCOS. With type 1, the insulin resistant PCOS, she touched on this as well. Having a healthy diet, exercise, weight loss. With the type 1, those symptoms can sometimes subside, and you can start to regulate your ovulation by doing some of those things. But with type 2, non-insulin resistance, you really may need additional help to achieve pregnancy. So, and weight loss isn't necessarily the fix for that type of PCOS. So, being able to achieve pregnancy naturally is a very likely thing. It's just figuring out kind of what you're working with, what type of PCOS you have, what symptoms you're dealing with, and then kind of forming a plan to help you. A lot of times it really does require, the help of a physician to help you understand what's going on, and some simple things that you can even do at home. It doesn't necessarily mean that you need fertility treatments or anything like that, but what you can do based off of your specific situation.
So it sounds like you're saying that there is a range of PCOS, and just like Nurse Linda mentioned, there are different symptoms. Do you have kind of a range of how long it can take you to get pregnant with PCOS? I'm sure it runs the gamut. Any further thoughts on that?
Yeah, absolutely. So it really depends on how often you ovulate. It depends on if you're getting some help, so if you are getting some help to ovulate regularly, or if you are a PCOS person that does regulate does ovulate regularly, you pretty much have about the same shot of getting pregnant as any other woman does. On average, someone without any fertility issues, it takes about a year to get pregnant. That's common. It can sometimes take less time, sometimes take longer. So it's very common that it can take about a year. But let's say you are somebody who only ovulates like every 3 months. Well, it would obviously take you longer to achieve pregnancy. So again, if you are doing some things to, help with the symptoms like weight loss and that kind of thing to help regulate your symptoms and then potentially have regular periods, then again, you're going to get pregnant the same amount of time that someone who doesn't have PCOS, could get pregnant. So it just depends on how aggressive you're wanting to be. If you're someone who, like I said, only ovulates every 3 months, but you aggressively are wanting to get pregnant soon, then you may want to seek some help so that you do ovulate every single month. And then that would encourage your chances of getting pregnant quicker.
And what are your suggestions for best dietary changes and supplements with PCOS?
Yeah, so as far as diet goes, I think a big thing that I see a lot of PCOS patients do, and I don't know what the rhyme or reason to it is. I mean, I do a little bit, but eating meals regularly. I see that a lot, that patients, that I've dealt with, they eat like one meal a day, and that is not good, especially when they're insulin resistant. So, eating meals regularly, having 3 regular meals a day, having healthy snacks in between is going to help quite a bit. There is some, thought process on, unprocessed foods, high fiber, low carb, minimal sugar, a diet rich in fish and poultry, starchy vegetables, that kind of thing. Anytime though you're thinking about doing a major modification to your diet though, you do want to seek your physician, for help and guidance, because, even though we are, experts or fertility experts, we're not your doctors and we don't know what your medical history is. So it's really important that you do kind of seek some personal medical advice, that somebody that can actually look at your history and guide you from there. As far as supplementations go, I feel like I get this question a lot, and I feel like people want me to say, oh, go to Walmart and get this, and buy this brand. But it doesn't really exactly work that way, because there's not enough studies out there to make us feel comfortable saying this is what's going to help you. There's no one quick fix, right? There are some studies that support inositols are helpful with symptom management, in placement of metformin, which is it's an insulin sensitizing drug, and then also actually in conjunction with it. But again, that would require, a doctor to kind of help you with that, to kind of see what your specific symptoms are, what your lab testing says, to decide if that's something for you. There's a lot of other things that are suggested, that they help, like zinc and fish oil. But again, we got to know exactly what's going on in your body to be able to say that that's really going to help you or not. And in the past couple of years, actually, it's kind of exciting. There's also some really strong studies suggesting probiotics are a big thing for PCOS patients. So there's basically these studies are suggesting that PCOS patients have some strains of probiotics that they're missing from their gut that are important, to basically that can actually impact their symptoms of PCOS, and specifically with their inability to lose weight. And so if we replace those probiotics, the thought process is that they'll be able to lose the weight that they're having a hard time losing, and then they'll be able to actually have regular periods. So that's something exciting to think about too. If you were interested in any of that, there are some tests that can be done. They're actually on a stool sample, to be able to see what strains of probiotics that you might be missing in your gut, and to replace that. So, and you can just go to your regular primary, doctor. You can go to your OBGYN, fertility doctors as well. So the theme of it is that you don't want to just go out and buy anything and expect it to work. But there are lots of things available to you that can definitely help you for sure, that are natural, that are not necessarily just some kind of prescription that you might need.
Okay, we did get a question on letrozole for
Okay.
PCOS. Can you touch on that one?
Yeah, sure. So letrozole, it's a little debatable as far as what's better, letrozole or Clomid, when it comes to PCOS patients. So with letrozole and Clomid, actually related to, so if for people who don't know, letrozole and Clomid or clomiphene citrate are two medications that help with ovulation induction. And so when you have like a PCOS patient that doesn't ovulate regularly, this can be very beneficial because it can help them have periods every month and ovulate every month to be able to get a chance to conceive every month. But clomiphene or Clomid and letrozole are actually the statistics on pregnancy are about the same with both of them. The only difference is that sometimes people choose, or sometimes physicians choose letrozole over Clomid because Clomid tends to not work if you are overweight and kind of in that obese range. Clomid doesn't work as well. So a lot of women with PCOS, not all of them, but a lot of women have issues with weight management. So that's why letrozole tends to be kind of the first line of medication, but it doesn't necessarily work any better than Clomid. It's just if weight is an issue, then letrozole would be a better option for you. But a lot of times, you do Clomid. If that doesn't work, then you do letrozole. And if that doesn't work, then you do what's called gonadotropins, which are injectable medications that are usually kind of associated with IVF, but can be used for timed intercourse or intrauterine inseminations instead of IVF. So there's lots of medications to help you with that. And I think, they were kind of interested in what are the side effects of letrozole or Clomid. Both of them, more so with Clomid, they do have side effects of like headache, dizziness, and that kind of thing. They usually subside when they're done taking the medication. So it's short-lived. It's usually about 5 days that they're taking the medication. It can be up to about 10 days, but about 5 days. So that goes away. And I know specifically with Clomid, usually it's suggested that you take it at nighttime so that when you're sleeping is when the symptoms would actually kind of develop and you don't even know. So then you don't know. I one time did take Clomid during the day and I felt like a crazy person. So it is much better. It is much better to take it at nighttime before you go to bed. But again, this is going to be under a doctor's order. So they're going to be able to, tell you when to take it, how to take it, that kind of thing. And the biggest side effect of all of these medications is multiple pregnancy. So that is a higher risk. And so something definitely to think about, because ideally we want one baby at a time. That's going to be the best option for mom and baby. And so with these ovulation induction medications, you always have the chance to develop more than one follicle. And so therefore you may ovulate more than one egg and then get 2, 3, hopefully not more than that.
Great, thank you.
One thing if I can add about the Clomid, Brianna is absolutely right from both a nurse and a patient point of view, is that us hardcore stubborn PCOS women, sometimes, I'm going to even say often, do not respond to the oral medication. For me, again, as a patient, I started out on Clomid, increased the dose the next one, and it just never worked. I never responded to the oral medication. That's common. Then you go on to, like Brianna said, to the injections, and you're trying to stay low level. So maybe you do timed intercourse, like she said, or inseminations. Well, the problem with that is when you're PCOS and the gonadotropins hit your body, remember I mentioned earlier, you have all these little baby follicles sitting there. Well, now they all respond. And like Brianna said, now we got, the woman who had the 6 babies or 7 babies. So I would do that. I tried that as a patient. And my IUIs, my inseminations were always canceled because all of a sudden, I made too many follicles, because it's not safe to ovulate, a handful of follicles and just put sperm up there. That's not safe, and then now you're stuck having to go do IVF. So just to support Brianna, absolutely correct. But don't be surprised if those oral medications like Clomid or Letrozole do not work for those classic PCO people.
Yeah, it does definitely take sometimes a trial and error of finding the right dosage and right medication for you. So it's very common. I always tell patients, if you start out on Clomid or start out even on Letrozole, like there's different dosages, and we just got to find the right one. So sometimes and sometimes it doesn't work, but a lot of times it does, because that's the good thing about PCOS patients is they've got a lot to work with, right? They've got a lot of follicles ready to develop. And that's actually the positive to PCOS. I know specifically when you go into IVF, I used to get so excited when we had a PCOS patient. I'm like, they are getting pregnant, man. They have lots of, lots to work with. Whereas, there's some other issues, as patients get older and, have diminished ovarian reserve and that kind of thing, it can get so hard. And so PCOS patients are kind of like, refreshing sometimes, because they do have such a better, better chance of pregnancy with these medications. It's just like she said, it definitely can be stubborn, and it may take some time to just really find what works for you.
Great, thank you. We do have a follow-up question that's related to this section that I'll throw out to the both of you. If you have PCOS, does your physician typically make you wait the standard 6 months of trying naturally before they'll provide an intervention?
So, I mean, it really just depends on what's going on. So if you have been diagnosed with PCOS, you don't have to wait, to go see to seek further treatments of any kind. If you have PCOS, then you already know that there's a potential that it could be a little bit more difficult, and also management of symptoms. So I would recommend no, but it just depends on, it just depends on what your thought process is. If you're thinking, well, realistically, I'd like to get pregnant in the next couple of years, then sure, wait 6 months, and try it on your own before seeking further treatment. The one thing I do want to really strongly that I didn't mention before is that, PCOS, take fertility out of it, you have such a higher chance, you do have a higher risk of, because of these metabolic kind of disorders, you have a higher chance of heart disease, blood pressure issues, higher cholesterol, diabetes, and that kind of thing. So it is really important to keep, take it seriously. I hope you've gotten across that, it's very hopeful to achieve pregnancy with PCOS. It really is. But it is a diagnosis that should be taken seriously, and it is something you're going to have for the rest of your life. So you do really need some kind of management on the medical side of things, whether you can get pregnant on your own at home or not. Because, these are serious things that may go unnoticed if you don't ever go see a physician. So I think that realistically, whether you're trying to get pregnant or not, it's really good to seek advice from a professional and just be able to live your best self, live your best life. And that's going to be helped by managing those symptoms and that kind of thing. And also just making sure you're healthy long-term, because they do have the potential to give you higher risk of these other things. So.
Thank you, ladies. Before we wrap up this section and move on to Dr. Haebe, any last thoughts, particularly Nurse Linda, from your experience about what helped you get pregnant with PCOS, lifestyle changes? Is anything you think we could still touch on that we haven't covered yet?
Sure. Well, it's funny, when I first started, again, I don't know, over 25 years ago, I actually went to the store to buy some ovulation predictor sticks. They had them usually buried somewhere in the back of a shelf because nobody bought them. They were about $1 million. You got like 3 of them, and they were usually expired. So there wasn't a lot of help back then. Not like now when I saw the Premom app. Back then it wasn't that easy. So I knew I needed to go to a doctor because I knew I wasn't having periods. So the first reproductive endocrinologist I went to did the whole exam, the whole thing. And he told me, I'm going to give you a referral to Weight Watchers. You just need to lose weight. And I think that will really help. Well, I didn't like that answer. Yeah, I knew I needed to lose weight. And if it was that easy, I'd already done it and I wouldn't be sitting here. So I didn't like that answer. So I went to another RE. I was actually going to nursing school. I went to an RE and I had insurance for IVF. So they were more than happy just to put me right into IVF. And I did 2 IVFs, hyperstimulated during the IVFs. It's another nightmare. IVF and PCOS is not easy. It takes a very special physician to be able to manage it. And I did not get pregnant. And needless to say, when I lost weight is when I would get my periods back, I would ovulate, and I could be a normal person and have sex at home and get pregnant. And that's exactly what happened 3 times. However, let's not make that sound easy. My 3 children are all 10 years apart. So I've been doing this for a really long time because it wasn't easy to always get pregnant. So it wasn't easy to lose weight. And that's, again, seemed to be, my body was more dependent on that. One thing with PCOS, and again, I remember physicians telling me, for me, because I didn't ovulate for so long, I ended up, my last child, getting pregnant naturally at 45. And that's, of course, at work, nobody believed me. Everybody assumed I used egg donor or did IVF, but I didn't. I wasn't using birth control because I'd been infertile most of my life. Why would I use birth control at 45? Well, there you go. So, and I didn't actually go through menopause until my early 50s. So everything took longer. And what did happen is my periods naturally became much more regular in my 40s because the hormones all start to calm down in all of us women in our 40s. And finally, mine went from this really high, stupid level down to almost normalcy right before I bottom out and hit menopause. And I was actually, for a few years there, a normal ovulating woman. During a time that it did me no good. When I needed it in my 30s, it didn't happen. So that's how it happened personally for me. And again, it turns out that first RE I saw was right for me. That's really what it required.
Thank you. Any last thoughts, Brianna, before we turn over to Dr. Haebe?
No, I don't think so. I'm excited. I think that, like I said, the biggest thing is just that there is a lot of options with PCOS. It's very common. 1 in 10 fertility patients have PCOS. So it's very, very common. And because it's so common, it means that we have gotten a lot of practice on how to handle this. There's a lot of information out there on how to manage it successfully. And, when you're trying to conceive and when you're not trying to conceive. So there's hope. This is not, this is not one of those end all diagnoses, that just because you're diagnosed with PCOS doesn't mean you can't have children, and so that's just something to kind of remember if you are struggling with PCOS, to know that there are so many options out there. There's so many things out there to help you and to make life easier for you when trying to get pregnant and when not.
Thank you. And I see we have a couple new questions, so if we have time, we'll circle back. But Dr. Haebe, let's talk a little bit about tracking with PCOS, how that works.
Awesome. So someone had asked if ovulation predictor kits are helpful in tracking ovulation with PCOS, and the answer is absolutely. Ovulation predictor kits, also called ovulation tests or LH strips, whatever you call them, those are all the same family. And they look for the hormone called luteinizing hormone. Luteinizing hormone is the hormone that is secreted from your brain, and it tells your ovaries, like, let's release an egg and get things going. So these are going to help you predict when you are about to ovulate, especially when you have these long, irregular PCOS cycles. They can kind of help us, give us a clue to what's going on. And we'll discuss a little bit about more about that in just a moment. Another question that we have, I have them written here. I just wasn't sure if Terry, you wanted to narrate them. Cool. I'll just roll. How much more work is getting pregnant with PCOS? And I think Brianna and Nurse Linda did a great job touching on this. it's more work in that whatever is wrong does need to be fixed, right? If it's an insulin issue, it needs to be regulated. If you have high androgens, we need to work on that. Also, probably part of insulin. Weight, we need to reduce that. However, it requires the same amount of tracking as everybody else does. You may just have to track for longer. You may have longer cycles. You may go through 100 pack of ovulation tests faster than somebody goes through, theirs. Not a problem. And the one thing I always say to keep in mind with that is don't be discouraged about taking tons of ovulation tests and the fact that you have to take them for a long time. These are a way to get like little pieces of information. So focus on that. Don't let it be like, oh, I have to, go through another, thing of LH strips. You're being a detective. Every single day you're getting information about what your body's doing. And it's really cool and empowering that you don't have to go to a doctor to figure that out. Like you can do that for yourself. Let's see. Okay, next question. How does LH rise when a woman has PCOS? Is it possible to have a false positive result with the LH test? So this is a good question. So LH rises when women have PCOS can look super different. It may be absent. You may have multiple LH peaks, or you might just have like small faint lines. And women with PCOS can have these super high levels of luteinizing hormone, which is sometimes people say, no, don't use ovulation predictor kits if you have PCOS. In these cases, think of it like this. Luteinizing hormone is super high because your brain is screaming at your ovaries saying, release an egg. And those ovaries are just not listening. They're tuned out. So in those cases, yes, you can have those elevated LH levels that aren't telling you too much. This isn't commonly the case. And it's important to keep tracking, even though those cycles are long, to see when you're going to get those peaks. So there's a few cases where they can be kind of frustrating to interpret, but I always encourage people to stick with them and continue on. Also, you can't really have a false LH test. If there's luteinizing hormone, there's luteinizing hormone. The only other hormone that could possibly show up on an LH test strip is HCG, the pregnancy hormone, which great. If HCG is turning your LH double line, then that's good news. But no, these LH strips are really going to only show LH if there's LH. Now, you can have an LH peak and LH be present without actually ovulating. So it's important that number one, you continue to keep tracking those LH levels using ovulation test strips, and also confirm ovulation with basal body temping or with urinary progesterone testing. And with this, especially with PCOS, one thing I want to touch on, especially if you're somebody that has those frequent small peaks or like those really faint test lines, Premom does make quantitative ovulation predictor kits, which can be helpful because they tell you not just if LH is present or not, but how much is present. So it's nice to put a numerical value on it sometimes, and that can give you a better picture. So if you have PCOS, consider switching from the regular ovulation test strips to the quantitative for a couple cycles just to get an idea of exactly where those luteinizing hormone levels are at for you. And then last question, almost done. Someone said they were diagnosed with PCOS, but they have a regular period. And she wanted to know, how can I for sure know that I am ovulating despite this diagnosis? So you can have a period without ovulating. So the first half of your cycle, estrogen builds up that lining. The second half, hopefully you ovulate. The corpus luteum produces progesterone. It encourages that endometrial lining to stay around and hang out. However, if you're not ovulating, you're not getting that progesterone production to keep that endometrial lining around. So you can still have a period without ovulating. It's just from a different absence of progesterone and progesterone withdrawal, if that makes sense. So what's important is to predict using luteinizing hormone ovulation test strips, and then also to confirm that you've ovulated. This is really important with PCOS. So you're all probably pretty familiar with basal body temperature. But one thing that I want to talk about today is urinary progesterone testing. Progesterone is going to be secreted by the corpus luteum after you ovulate. And it's really not going to be there otherwise, unless you have some strange adrenal neoplasia or something that would cause you to have high progesterone levels. So there's a urinary metabolite called PDG, and we can actually test for that with urinary test strips about 5 to 8 days past your LH peak. and it can confirm that you ovulated. So this is a super, super good tool for people with PCOS. And I always say this is like your secret weapon if you have PCOS and you're not really sure what your LH spikes are doing. Consider adding in these PDG test strips. We're going to start carrying them in December, which I'm really excited about because I think especially for the PCOS community, these are essential to use in that second phase of the cycle to confirm that ovulation. And again, basal body temperature, you're still looking for that thermal shift due to progesterone, which increases that internal body temperature. These progesterone test strips are just another way of double checking that. Or if you hate temping, this is another option for you to do just a couple times a month.
Awesome. Thank you. I think you just covered a bunch of questions that came up live too. So we'll just knock those out. We do have a couple of other questions, and thank you, Dr. Haebe, for reading my mind in the quantitative strips. I was like, oh, and then you did it. That was great. We're going to open these up to anybody. If you want to just touch on these quickly before we close up today. There's a question about suggestions for lowering cholesterol if diet and exercise aren't working and your weight is normal.
Can I actually have a point on that? Just from an integrative perspective, as far as cholesterol goes, I kind of love it around. If it's in scary ranges, we want to be careful with it. But when we start jumping into the statin realm and everything and dropping those levels too much, cholesterol is actually a building block for all of our sex hormones. So if we're going to pull that and tank that too low, we actually not only have trouble helping our mind function as it should, but we also have trouble synthesizing hormones as we should. So I would say, a cholesterol around 200 is actually okay in my opinion. Again, clinically, it has to be okay with your doctor. Our focus is to focus on decreasing inflammation in your body and making sure that cholesterol doesn't have negative effects and future complications. So fish oil, healthy diet and lifestyle, anti-inflammatory diet, super important. But just a little one piece I always have to say about cholesterol because I'm a big fan of it.
Thank you. How about, there's a question, has anyone heard of PCOS correcting itself naturally?
I would say that usually when that is the case, I've heard people say, yeah, I was diagnosed with PCOS, but now I don't have any symptoms or whatever. Usually they're not really diagnosed with PCOS when that actually comes up. So, or they say, I was told I had PCOS, but it's usually the patient's perspective is that a doctor said, hey, you may have PCOS, but no testing was actually done to confirm it or not. And then there's also some variations to, like, if you're managing symptoms or weight loss or whatever, and the symptoms go away, that means that you're not struggling with the symptoms of PCOS anymore, but it doesn't mean that you don't have it. Does that make sense? So it really is a lifelong thing. Unfortunately, it doesn't mean that you're going to be constantly struggling with it. Doesn't mean that you're going to have symptoms of it, nonstop every single day, but it is something that is in you, that does, like we talked about, it does increase your risk for some other things down the road and that kind of thing. So like I said, it's something serious that you should take seriously. And just because you don't have the symptoms of it, but you did before, that doesn't mean that you don't have it. So it's just important to actually, if you are potentially struggling with it, to go get diagnosed so that you know for sure that you actually have it or not, so that you can take it seriously throughout your life. But also, if you're not necessarily struggling with any symptoms or anything like that, that also doesn't mean that you don't have it, So it's kind of one of those things that you really do need to seek medical advice and get the testing done to be able to tell you if you actually have it or not.
Great, thank you. And then we have one more question, and then after that, I'd like you ladies to just give any final thoughts on this topic. The last question is, I just turned 39 on Wednesday. I already feel like my window is quickly closing, and I feel like there's a stigma around being older and trying to conceive. Any thoughts or advice around this?
Was there a PCOS I'm sorry, in the question, or was it just, is this an age-related thing?
Related to PCOS. It's more like just trying to get pregnant when you're older. Any quick thoughts on that? Or we could save that for
Well, it
another
gets
one.
more, yeah, it gets more difficult as you get older, that's for sure. Obviously you can't answer the parenting question. That certainly varies person to person, but certainly it's possible. When you get pregnant when you're older, you have to be aware these were older eggs. And so there's a higher likelihood either of losing the pregnancy because it's abnormal, or even, more sadly, getting pregnant with an abnormal baby. And having to do either CBS or amnio to assess that, which of course is encouraged as you get older. So it's more difficult, and it could be a more problematic pregnancy. So those are just things you have to be aware of. But of course, you'll have either a perinatologist or an OBGYN that would counsel you on that. But yeah, it is more difficult. It's more difficult to do almost everything as we get older, and conception is not any different.
I would say, in addition to that, completely spot on. But also I would not say, don't lose hope. Get all the antioxidants in that you can, decrease your toxic burden, try to protect those eggs the best you can, make sure you're as healthy as you can be to host that healthy pregnancy, give yourself the best chances. Again, anti-Müllerian hormone, a hormone we use to judge ovarian reserve, can be gorgeous sometimes at 39, and sometimes it's non-existent in people who are 25. So I would say, investigate, see where you're at, see if you need to get interventions early. But otherwise, just take really good care of yourself, and you're absolutely not alone. The rates of, older pregnancies are growing like crazy, and there's nothing wrong with that. So again, yes, absolutely increased chances of risk, but take the best care of yourself. And if you know in your heart it's a good decision for you, then totally possible and totally being done.
And
another good point is that, as we get older, we're always told about these abnormal eggs. And I always tell my patients, you are genetically chromosomally normal. Your eggs are chromosomally normal. Right now, there's nothing wrong with your eggs. They're fine. They're older, like my joints are older and my liver's older and everything else is older, sure. But right now they're chromosomally fine. They just have a really important job to do in order to conceive a baby. You have to divide the chromosomes in half in your eggs. And of course, the sperm did the same thing. Easy for the sperm. They're only 2 or 3 months old. My eggs are 39 years old in this case, and they may not divide their chromosomes so well because the parts and pieces inside the egg are 39 years old. So that's where a lot of the issues come up. But I always want to tell my older women, you're perfectly normal. Your eggs are perfectly normal. They just might not, do as well. Like I can't run around the block as well as I could, 10 years ago. So you're not abnormal. Your eggs are not abnormal.
And she did follow up and say she does have an issue with PCOS, the one who asked about conceiving when you're older. So yeah. Okay. Thank you very much, ladies. Any last thoughts before you wrap up today?
There's hope.
Dying to share.
There's hope. I run into so many PCOS patients that say, I can't get pregnant because, my doctor told me I have PCOS and I'm not going to be able to have children. And that is not the case. Obviously, Nurse Linda down there, she's a perfect example of it. So I just would love to end on the fact that there is hope. There's lots of tools out there to help you. I know I'm a broken record, but just know that you may need a team behind you of people to help you, and that's okay, and to help kind of guide you. You may also be able to figure it out completely on your own. Like there's just such a wide range of PCOS patients, and the seriousness of it and the symptoms and all of that. So just knowing that it's okay to seek help. It's, and you may be able to, get where you need to go a little bit quicker if you do have some people to help guide you. But there are so many things out there to help you, and you can do it.
Thank you. Anybody else?
Yeah, definitely. I just say don't be afraid to seek out help early. Get a second, third, fourth opinion if you need to. Look into different type of specialists, and just find a doctor or some sort of practitioner that's willing to listen to your needs, look at your picture, and dig in deeper. Because maybe your lab's normal, but you don't quite feel normal, things aren't cycling normal, doesn't mean that you're wrong. And things just may need to be investigated a little bit deeper. So be your own advocate for sure.
Okay. All right, and you can find these ladies right in your app if you need an extra advocate. Right through Premom, if you go to more and schedule a consultation, you can find Nurse Linda, you can find Brianna Kane, you can find Dr. Haebe, and they can assist you as well as other consultants that we have through the app. Thank you so much, ladies. This was amazing. Every time we do this, I'm just blown away by the wealth of knowledge that you have and the compassion and the eagerness to support our community. So thank you again for being here today. And for those of you watching, thank you for participating, and we'll see you again soon.
Thank you guys. Thanks everyone. Have a good weekend.